Presentation of dialogue on Idaho Public Television is made possible through the generous support of the Laura Moore Cunningham Foundation, committed to fulfilling the Moore family's legacy of building the great state of Idaho.
Coming up, he says both good doctors and good literature can heal. A conversation with physician and best-selling author Abraham Verghese, next on Dialogue. Hello and welcome to Dialogue. I'm Marcia Franklin. A welcome as well to those of you tuning in on public radio and the World Wide Web. When Dr. Abraham Verghese, a talented infectious disease specialist, started his career, he suffered from what today he calls the conceit of cure. Not many illnesses, he thought, were immune from the skills of doctors and the magic of medicine. Then AIDS hit. Dr. Verghese, then practicing in rural Tennessee, found himself overwhelmed by the number of AIDS patients coming to see him. Men who had grown up there, left, and then had come home to die. In the book, My Own Country, Dr. Verghese would chronicle how those patients, who he could not heal, would in fact change him for the better. And then, drawing on his roots as an Indian growing up in Africa, in 2009 he published his first novel called Cutting for Stone. With medicine as its backdrop, the work follows the saga of two brothers as they unravel the mystery of their existence. I had the chance to speak with Dr. Verghese at the Sun Valley Writers Conference. Since 1995, the conference has been bringing together accomplished and thoughtful writers for discussions about literature and life. I started by asking him to describe a bit more about the inspiration for his story. Now, this story literally came about with a vision that you had of one of the main characters.
Indeed. For the longest time, I had this vision of a nun, a very beautiful Indian nun, giving birth to twins in a mission hospital in Africa. And I don't quite know why. I think the whole idea of nuns is always fascinating to us. They're people who hold themselves up as answering to a higher calling, renouncing the world. They fascinate us that someone can have that kind of discipline. And I think when they turn out to be somewhat flawed, although I don't think of her as flawed, human, I think it greatly interests us. It interests me anyway, and so that's all I had, and I pushed that image and the voice forward for the next 7 years to get the book.
Well, the main voice of the book, the story is told mainly from the point of view of one of those twins, her son Marion, who becomes a doctor. We could spend a whole half hour just talking about the plot, but it seems to me in its broadest terms that this is a love story, not only about familial love or love between couples, but the love of medicine and the medical arts, which you share.
Yeah, I think Cutting for Stone is definitely a love story, and as you say, I think it could be construed about as being a love story about family, about the traditional love between men and women, but it's also very much about my passion for medicine. And you could argue that every novel out there is a medical novel at some level, to the degree that it's involved with life and death, and it's a medical novel. I think mine is much more overtly medical. Every character in there just about is a physician or a nurse or involved in medicine in some way. And I've always felt that medicine is a calling. It's not just a trade. And I felt a strong sense of calling going into it. And one of my one thing I'm sad about is that I think that there are many young kids out there who perhaps have a calling to medicine that they don't know about, but may not see medicine as a profession where you have a calling. They might see the priesthood as a calling, but medicine unfortunately has lost that dimension to it. And I really wanted to speak to that because it's very much alive and well in me. I still feel the passion every single day that I go to work.
And you've said that you will consider the book to be a success, not necessarily from any awards or sales, but if it convinces at least one person to become a doctor, to go into your field.
Absolutely. So with my previous two books, I've been very gratified with the success of the books, but I have saved in a very careful fashion every letter I got from a college student saying, this is the book that brought me to medicine, or this is the book that took me to infectious disease. And I'm waiting for that kind of a letter from this novel. I mean, I think that would be my greatest pride if something like that happened.
I spoke to a doctor who read the book, who actually devoured it. He loved it. And he said one of the things he found so interesting is that although the character, like yourself, is practicing or is from Ethiopia, what he found so interesting was reading it was the universality. He said, this character feels the same way about medicine that I do, even though he's from a completely different country. And it very much struck him that there was this common language of doctors, which he had never really thought about before, I guess.
Well, that's quite intriguing. I think that's, you know, people say that about novelists and their characters in general, that your character has to be, on the one hand, absolutely specific and unique. And yet the reader is going to love it because there's something archetypal about the character. So I guess in that sense, you know, these very unique and different physicians I created in the book are unique and different, but they hold to a universal archetypal truth that I'm glad to find that the doctor you spoke to subscribe to, and many doctors do.
Well, one of the manifestations of that commonality between doctors is the Hippocratic Oath.
Yes, indeed.
And I know you take great pleasure in standing with your students and reciting that oath.
Yes,
And
yes.
the title of the book comes in part from that oath.
Absolutely. So there's an antique line in the Hippocratic Oath that says, "Thou shalt not cut for stone." And you know, one of the seminal moments of my year, a renewal, is to stand with the students and take the oath at graduation. And you know, they stand, the faculty stand. In the audience, all the physician members stand too. And you know, that line never made a lot of sense to me. Thou shalt not cut for stone. And it turns out it has to do with a proscription against cutting for stone in the medieval times, when bladder stones were very common. They were skilled at getting the stones out, but people died the next day from sepsis because they knew nothing about antisepsis and, you know, sterility. And so, you know, when I was looking for a title for the book, that line always had been in my head, cutting for stone. All the characters are surgeons by and large. The family name is Stone. So I was hoping that it would, you know, resonate for the reader at many different levels.
And you've also said that you felt that this book shows how medicine can save you, but it can also destroy you and humble you. What did you mean by that?
Well, you know, I have a great love for medicine. I think that in 20 plus years of practicing it, I have seen the glories of medicine, but I've also seen its seamy underbelly. You know, I think that the epidemic of suicide amongst physicians, we have the highest suicide rate in the country. Doctors, lawyers, and dentists, 20-fold higher than school teachers or other professions. So I think, you know, just as medicine can be satisfying and you know, joyful, it can also be the cause of great misery. So my thesis is that I think a lot of people go into medicine perhaps the same way people go into the priesthood, with a sense of being in some way not okay. And by going into the serving profession, you're finding a way to deal with your not okayness, which is quite legitimate. I think it's a very good reason to go into medicine. The flip side of that is that it can swallow you whole if you sort of get consumed by it to the detriment of your own personal health, your family welfare, and you know. So that's what I meant by that. It can save you, it can kill you, and striking that balance is very delicate.
Well, you've written very eloquently about a humbling moment for you as a physician in my own country when you recognized that all these patients with AIDS were coming into your rural community. And you've talked about the fact that prior to this experience in Tennessee, you felt you were living in kind of a conceit of cure era.
Yes, I think that's still true for a lot of physicians who are still living in the conceit of cure, but it certainly was true of that very golden age in the mid-'80s and early '80s, where, you know, we were transplanting routinely, we were coming up with new cures for leukemia. There was you know, an incredible sense of there was nothing we couldn't fix. And if we couldn't fix it, it was the patient's fault. It was bad protoplasm, aged protoplasm. And I think, you know, out of that conceit came a kind of hubris. And it was so ironic that someone like me, specializing in infectious diseases, which I went into because it was all about cure, should find myself dealing with a ultimately fatal illness for which there was no cure. And it was a very humbling lesson.
And although there is no cure for AIDS, there's kind of a cocktail of medicines that allows people to live longer. And that must be very bittersweet for you to look back on the patients that you lost and know that time was not on their side if they just been able to hang on for a
I
couple
know, in
more
fact,
years.
I can think of one or two individuals who just barely missed the arrival of the cocktails. And so, you know, I think this is true of all of us in infectious disease. We lost hundreds of patients who we can all remember. We remember their names, we can see their faces and remember them wasting away. And, you know, frankly, I became almost nihilistic. I never had faith that we would one day turn the corner. And so when it happened, I was completely unprepared for it. And what it has done is it's made the disease very much like diabetes in a sense. You can't cure diabetes, but you can certainly control it, and people can live a nice long lifespan and have any complications that happen at the tail end of a lifespan rather than bang in the middle of your life. And so in that sense, it's been a huge success story.
As an outsider, as somebody coming from another country, did you feel something in common with these patients?
Yes, I did. I was, you know, the bulk of my practice was in small town Tennessee, and you know, I was an alien in that town. There weren't many people of my skin color in Johnson City, Tennessee, and yet I felt, you know, quite welcome. But I wasn't always, I was never quite, you know, lacking in consciousness that I was a foreigner there. And so it was very interesting to meet these patients who ultimately were hometown boys who had gone away because they were gay, got infected in the big city, were coming back, and to realize that even though they looked the part and knew all the rituals of Friday night football and possum pie and all that, you know, really at heart they were more alien in that town than I would ever be. And that was, you know, in many ways that's why they came to me. I think there was a sense that they had that I would not judge them, or perhaps they even thought I had no right to judge them, because in a sense, you know, whereas if they went to one of the local docs, it would have been like going to one of their uncles or, you know, an avuncular figure who might well be a family member or connected. There was no such fear with me. I was someone from another world.
We're seeing more and more doctors coming from other countries to practice here. We don't turn out enough medical students to fill the gap. And what do you think these doctors will bring with them that will add to the practice of medicine? What perspectives?
Well, I'm not sure that we're seeing more and more. I think we've always seen a huge number. I think it's sort of one of the things that people aren't that aware of. But the fact is that one of the ingenious ways that Medicare discovered to treat patients in inner city hospitals where no one would be willing to go and, you know, set up a practice or be employed by an inner city hospital was to set up training programs and fund graduate medical education. And that's a brilliant idea, but there still weren't enough medical students to fill those positions. And so every year for years, something like 5,000 to 10,000 physicians come pouring in to fill this need. And I think one of the lovely things about America is that when America has a need, someone comes in to fill it, whether it's corn detasselers or chicken pluckers or, you know, 7'2" basketball centers. America's need, the world obliges. And, you know, I do think that part of the reason that we have this need is because of a peculiar paranoia on the part of the American Medical Association, which for years claimed that there were too many physicians. I think they were fearful of competition and so on. It's clear there are not enough physicians. There's certainly not enough primary care physicians. So we're left with the schizophrenia where we have too many positions to fill, not enough medical students coming out, and a body that, quotes, represents physicians. They don't represent me, claiming that there are not enough, that there are too many physicians.
Well, one of the things that you've written about, that you were taught in schools in India and Ethiopia, was more of a sense of touch with your patients, a closeness that I guess many doctors now don't have. I remember my own doctor as a child percussing me. You know, I remember his hands on me, and he was so gentle, frankly, that I never grew up having a fear of doctors because I had such a good experience with him. My dentist, that's another story. But you really bemoan the fact that this sense of touch and closeness that you learned in medical school is gone or going.
Yes, and I don't want to overstate it. I think that what it represents really is that in most other countries, Canada included, England included, there is not the sense of being able to order every diagnostic test in the world anytime you want it. Someone has described our healthcare system as being like a menu without prices. You know, you roll in, and if you want filet mignon, 2 orders, and you know, a double helping of this, you just tick it off and you order it. You don't really worry about who's paying for it. Whereas I think in other economies, you have to be pretty judicious about ordering expensive tests. And therefore, so much is riding on examining the patient well, taking a good history, and out of that, deciding judiciously to get this test and that test. I think it's a great way to do medicine. It's cost effective, and it also allows you to bond with the patient because you're spending so much time percussing and so on. What's happened here is that there are these perverse incentives that actually encourage testing in some settings but not in others. For example, in the emergency room, by and large, the more tests you order, the more money the hospital will make. But in the hospital, when you're admitted, that's not true, because reimbursement is by disease, not by number of tests. So, you know, there's all these strange reasons why we get so many tests, and then it seems like, well, I already know what the inside of the belly looks like. There's no point putting my hand there. And I think all this adds up to the great gulf, the great distance that is developing between the American physician and their patient.
You talked about the eye patient.
Yeah, well, I talk about the eye patient, how, and by the way, I should not say that this is manifest with every physician,
Sure.
Far from it, but there's clearly a trend where, you know, sometimes I worry that the patient in the bed has become a mere icon for the real patient who's in the computer. And you go to see your doctor, it's not uncommon these days, you're sitting there, the doctor's sitting here, but they're turned facing a computer and not making eye contact.
I've had that experience.
You've had that happen. All the things that we hold as being fundamental tenets of clinical practice are being violated by this obsession with data gathering and data keeping. And to be fair to physicians like myself, all the incentives out there, all the ways that the government pays doctors have to do with doing things to people as opposed to for people. The physician who spends an hour with your father learning his story won't make as much as if he had seen 3 or 4 patients and spent 10 minutes, which is what actually is reimbursed at almost a higher rate sometimes. So it's really quite absurd. And you look at very busy practitioners and you wonder, why don't they spend more time with their patients? Well, the way Medicare and other insurance companies pay primary care is such a pittance that to pay the overhead, they simply have to churn out these numbers. And you know, nobody's happy with it, least of all physicians, I can tell you.
Well, the same doctor that I mentioned who had read your book, when I asked him what he felt about this issue, he said, well, sure, I'd love to do that, what he's talking about. If I did it, though, I'd go broke.
Exactly, yeah.
Is there a country or a place or a community maybe here in the United States that you think is doing this better, well?
Well, I mean, clearly there are models of care that are inherently within their closed system very good, such as the Mayo and the Cleveland Clinic, but they are not providing free care. They are providing care in a very closed system, in a very efficient way. The Kaiser system does a great job of it. But I think we're talking about the most critical thing that I think people fail to always register is that ours is a very expensive healthcare system, $2.1 trillion. And yet we're providing care which in some respects is worse than a third world country in terms of maternal mortality, childbirth, all those kinds of statistics. So it's a question of distribution, and I think the biggest problem we have is the prices that have been set are completely arbitrary. And I think many of us feel that a real function of government, just as they do with utilities, by the way, just as they do with the roads out there, is to hold down prices, to make basic things like electricity, water, you know, affordable, and not have us gouged out of existence by needing water or electricity. I think that function of cost control is really where the government needs to step in. And it'll hurt a lot of people who are making great money on this, but I think it's necessary.
Including doctors who now have interest shares in freestanding MRI centers and such.
Yeah, so I mean, I think I've become unpopular with my peers to some degree, but I don't think they can say that I'm not being truthful, but I have gone on record to say that I think we in medicine are corrupt. To the degree we can allow ourselves to, you know, own a CAT scan facility, an imaging facility, have shares in a hospital, and believe that we can be ethically, you know, we can be completely, you know, unaffected by that fact when we admit a patient to the hospital or send them to our own facility. You know, I think those kinds of conflicts of interest are rampant, and frankly, if you want to sort of see who's most conflicted, just look at where the opposition is coming to for health reform. There's a lot of people who have a lot to lose because they're making gravy right now. And I think, so it's very delicate. I mean, I'm certainly not suggesting that I am immune to that. I put myself in that group. I think the corruption is so insidious that we've all been affected. But you know, that shouldn't be. We should have been the ones to police ourselves and say, you can't do that. You simply cannot do that. You cannot take billboard ads advertising your services. You know, when did all that slip away from us? It's happened. We've become, you know, plumbers essentially at some level.
Do you see a way through the thicket? You know, some have called for more public financing of the system, and as we speak, there are meetings going on about this, and there's just a lot of fear and contention about quote-unquote socialized medicine.
I know there is a lot of fear. I think the one truth that's finally sunk in, which it was actually true about 8 years ago or longer, but I don't think we were ready as a nation to tackle it, is that if we do nothing, things will just keep getting worse. And so people who are very comfortably insured, presumably you or me, we can't rest assured that that will continue. You know, so many of the people who are very worried about health care reform are the ones who have insurance. But frankly, it's very possible, very likely, almost certain that as time goes on, the cost of our insurance is going to go up to the point where your employer or mine might say, you know, I just can't afford to buy this for you. So you'll have to buy your own insurance. That's going to happen. So I think that's the push that I think is driving the healthcare discussions. And my hope is that people will accept that having a government entity that provides good health care will force insurance companies and others to just be competing a little more fairly. Right now, an insurance company's overhead can be about 30%. Compare that to Medicare with a 1% overhead. So for all our complaints about Medicare, they have a very small overhead. The 30% overhead of an insurance company is spent to a large degree cherry picking to make sure that they don't cover anybody who's going to cost them. So they invest a lot of money screening people so that you're unlikely to ever need the services that you're paying for. Now that's just not fair, and I think in other civilized societies, the government forces insurance companies to take some of the risk and pool the risk. The government sets caps on prices just as they do for electricity, water, telephone, and so on. I think that we are more than ready for that as a society, and I think clearly there's a lot of opposition, there's a lot of fear, there's a lot of false stories going out there, but I think the mood is right, and my sense is that we're on the right path.
And you're in an interesting position now at Stanford to influence a lot of students going into the system about some of these issues and becoming closer to their patients, hearing their stories. You've talked about how you think the American Medical Student Association actually is moving in a direction that you like.
Yeah, I have great hope in our students. I think it's a function of studenthood, but maybe more so now than ever before, that you know, this generation of students didn't come to medicine to make money, in the sense that, you know, they came into medical school knowing that there were problems down the road, knowing that you know, the days of you know, making a lot of money in medicine are probably gone. So they're more idealistic, and I have great hopes that they will keep us honest. It's really refreshing to read their website and compare to the websites of our, you know, official organizations. They really make us look bad, I must confess.
I don't know how you pack it all in, all of these issues that you write about, and novel and nonfiction.
Well, they're all one, aren't they?
It's
I mean,
incredible.
you know, I always resist the temptation to have my writing categorized as different from the medicine. I really think it comes out of my wellspring of love for medicine.
And you've actually said that you're surprised more doctors don't write because of the incredible stories that they hear every day.
If they're listening, yes, indeed, yes.
That great literature in your mind has this power to transform people, that if more people read, it'd be a better world.
Oh, definitely. I mean, so if you think of Uncle Tom's Cabin, I mean, look at that. One book really was at the heart of the emancipation movement, and perhaps did more to abolish slavery than any individual ever did. So talk about stories being compelling. So I think there's great possibility for stories to sort of reveal the injustice that's out there and to speak for solutions. So I don't make any, you know, claims about my book in that sense, but I do make claims that fiction is terribly important, and I'm very impatient with people who say, well, I don't read fiction because it's made up. And I think, it may be made up, but if it resonates, it's because there's a kind of truth that you'll never get any other way. So what I like to say is good fiction is like you've just stepped into a spaceship, you've gone to another planet, you've lived a whole life, 50, 60 years of it, maybe even more, generations of it, and you come back and it's only Tuesday, and you have all these lessons of a lifetime to come back with you. That's what a good book should do.
Well, one of the outcomes of your ability to listen to your patients was, as you said, you were humbled by their stories and saw them as patients, not just the disease that they had. And there's an essay that you wrote called A Touch of Sense, and I just thought was beautiful. And I wondered if you would read the very end of this. It's about the importance of the ritual, as we discussed earlier, of actually touching the patient.
Right.
And it's about an AIDS patient who was dying his last hours.
Yeah, just to set this up, I should mention, so this patient was dying, and when I went to see him, he was almost immobile. He would die in an hour. And he had been immobile, and when I got there, when he saw me, he started to fumble with his buttons, and I realized that he was wanting me to examine him just as I did every time I went by. And so it was an object lesson in how the ritual is terribly important. So that's to set up the piece. This ritual was about the one message that physicians have needed to convey to their patients. Although God knows of late in our hubris we seem to have forgotten, we seem to have drifted away as if with the explosion of knowledge, the whole human genome mapped out at our feet. We are lulled into forgetting that the ritual is cathartic to the physician, necessary for the patient, forgetting that the ritual has meaning and a singular message to convey to the patient, and the message, which I didn't fully understand then, even as I delivered it, and which I understand better now, is this: I will always, always be there. I will see you through this. I will never abandon you. I will be with you through the end.
Dr. Verghese, thanks so much for taking the time. I'm sure there's many people who would love to have you as a physician.
Thank you very much. Thank you for having me.
You're welcome. You've been listening to Dr. Abraham Verghese, a professor at the Stanford School of Medicine and a best-selling author. I spoke with Dr. Verghese at the Sun Valley Writers Conference. I'd like to thank the conference organizers for making their speakers available for interviews. To learn more about the event or to check out my other conversations from the conference over the years, go to the Dialogue website at idahoptv.org. Thanks for tuning in. I'm Marcia Franklin.
Presentation of Dialogue on Idaho Public Television is made possible through the generous support of the Laura Moore Cunningham Foundation, committed to fulfilling the Moore family's legacy of building the great state of Idaho. To order a copy of this program from Idaho Public Television, call our toll-free number or visit us on the World Wide Web.